Okay. Okay, let's start again from this slide. Sorry if I repeat this, but I want you to have in your mind these things. We see here the insular surface, okay, and then we see the extreme capsule, which is a subcortical white matter of the insula together with the claustrum. And then we have the external capsule, that it's continuous with the IFOF and the uncinate. And then, of course, you have the putamen with some corticostriatal fibers, which are the most superficial coming in here. Corona radiata or central semiovale, that will be continuous with internal capsule. And I didn't emphasize when I showed the central core that when you see the insular surface, you have the central core right in here, okay? The posterior half is related with the thalamus, and the anterior half of the insula is related with the head of the caudate, and of course then you have the body of the caudate going around and superior to the thalamus. So when you see this, besides seeing all these layers that we're talking about, you have to have a perfect idea of the central core. Okay, the thalamus then is projected underneath the posterior half of the insula, thalamus, and of course you have the posterior arm of the capsule underneath, medial to the thalamus. The thalamus is the head of the brainstem. You would have the brainstem, and the anterior half will be related with the head of the caudate. And then, of course, superior will have the body of the caudate going around the thalamus superiorly, okay? And the foramen Monroe then is pretty much, if we know that the thalamus in the posterior half, we know that the foramen Monroe is superior and anterior. So it's pretty much here, okay? And of course, we know that the genu of the capsule will be right here, because genu of the capsule is just next to foramen Monroe. So you really have to exercise this topographic X-ray vision. And this thing about concepts, you have to understand that internal capsule is a concept, corona radiata or central semiovale another concept, and sagittal stratum another concept. And sagittal stratum has a lot of fibers all together, you know, and why we have this concept? Because when we talk sagittal stratum, we're talking about the lateral wall of the atrium and lateral wall of the inferior horn. So to get to these cavities, we have to go through all these fibers. And remember that you have here the anterior commissure fibers, you have the IFOF, uncinate fibers will come more anteriorly, and then underneath all this you would have the optic radiation. And underneath the optic radiation, you have the tapetum fibers. And the superior longitudinal fascicle doesn't belong to this concept. It's another concept. Okay, you have the horizontal part, you have the vertical part, and you have the inner part, which is the real arcuate fascicle that deals more with the phonological aspects of the language, according to Dufour, while the IFOF deals more with semantic aspects of the language. And of course, this is all a perisylvan network circuitry that deals with languages in this broad sense. Temporal stem is another concept that it's used every day in neurosurgery, okay? This concept came with this author, Horel, and he was not exact when he meant. He didn't describe temporal stem. He was referring to this radiological and anatomical aspect of a coronal cut of the temporal lobe, where you have sort of a stem, you know, where the segments here of the white matter of the temporal lobe, namely from the superior, medial, and inferior temporal lobe gyri, superior, middle, and inferior temporal gyri, and also from the fusiform and the parahippocampal gyri. You have these branches here of white matter that they get together and they give this pictorial appearance of a stem, just like a tree. And he called all this temporal stem. He was referring to this at this time. And then you have this Montreal school of Penfield. Penfield also used this word temporal stem, here referring to Penfield in a paper by Professor Rasmussen and Feindel, who followed White of Penfield. And you see that in here they are referring to all these things all together here. Pretty much the same thing that Horel described, temporal stem, temporal stem. Now, if we look close to here, if we see in the anatomical specimen, you see the insula. We're going to be talking this the afternoon. The insula has what used to be called a circular sulcus. Now we call superior limiting sulcus, and inferior limiting sulcus and anterior limiting sulcus of the insula. And you have the inferior limiting sulcus. This is an inferior limiting sulcus. Inferior limiting sulcus of the insula that you could see here, okay? And if you go deeper, you see that all this was called temporal stem. But what we are seeing here, we are seeing the sagittal stratum that we talked about, lots of fibers here. And if we remove this, we see that we have another component here that looks like a peduncle, like this peduncle here. You see a peduncle, and then you have the inferior limiting sulcus that was covered here by the sagittal stratum. So let's come back here. You have a sagittal stratum here, which has fibers that do not belong to the internal capsule, like the anterior commissure, like the IFOF, and you have fibers that belong to the internal capsule, like the optic radiation, and auditory radiation would be more superior to all this we're talking about. So you have these fibers, and you have a real peduncle here. You have a real peduncle here. That it's something different. What you have in this peduncle, you have the uncinate fascicle, you have the IFOF posteriorly to the uncinate fascicle, and you have a superior extension of the amygdala that go towards the globus pallidus. I'm sorry if I didn't emphasize this, but I'll return to this. Oh, here. So if we come back to this dissection, you're seeing the globus pallidus, you're seeing the channel of Gratiolet, where you have the anterior commissure that was cutted here. Anterior commissure fibers will be coming here towards posteriorly, and this is mainly optic radiation fibers, okay, that belong to the retro-lentiform part of the capsule. You have the accumbens or ventral striatum. This is already caudate, okay. This is head of hippocampus, and what is this here? Amygdala. And you see how beautiful this? I didn't emphasize this. The amygdala is continuous with the globus pallidus. Amygdala, remember in one of the first dissections that I showed that the caudate comes with the stele around the pulvinar, and then comes part of the roof of the inferior horn. Doesn't belong to the sagittal stratum. This is lateral wall. We're talking about the roof inside there that is not being shown here, but remember that the tail of the caudate will end up merging with the amygdala down at this point here. We'll come back to this. So caudate merges with the amygdala, and the amygdala is superior continuous with the globus pallidus. I never saw a dissection that showed this so clearly, okay? And then you have amygdala, you have ansa peduncularis here that we talked about, okay? So this belongs to the sagittal stratum. So if we come back here, you see the amygdala that will be here will be down there, continuous with the globus pallidus, and this peduncle is something different than the sagittal stratum. So the first descriptions of the so-called temporal stem did put all this together, and this is not very clarified in the literature yet. But for us, it's important to understand the anatomy. The concepts are just something that it varies between authors, but we'll come back to this. Remember that if you take the uncus, you have the amygdala, the anterior half, and the head of hippocampus, the posterior half. And where does this come from? Come to? You see, you can see this. This is the beginning of the insula, liming insula. We're going to be talking about this, and this very dark area is the base of the putamen, okay? And then you have the globus pallidus here that it's more pale, more white. So the amygdala would be here. This is head of hippocampus. The amygdala would be here, and the amygdala will be continuous with the globus pallidus. That's why the choroidal fissure starts at the level of the head of the hippocampus, because everything here is incorporated at the frontal base, at the basal forebrain. So coming back here, sagittal stratum. If we remove the sagittal stratum, okay, we have this peduncle here. So you see all different description of temporal stem. But Professor Yassar-Gil, who is real father of all this microneurosurgical concepts, initially he did admit temporal stem as a concept. Then he said that there's no temporal stem because then we would have frontal stem, parietal stem, and everything. And then again he said, okay, I think temporal stem refers to this peduncle here. Because the sagittal stratum is just a continuation of fibers that you can have in different lobes as well. Now, this peduncle here is something unique of the temporal lobe, incorporating in the frontal basal brain. Okay, so that's what we understand about the temporal stem. Not all these things, but some authors consider everything temporal stem. Personally, I think this is temporal stem, just many authors, Touré and others. This peduncle, you have the uncinate fascicle, you have the hypoph, and you have the superior extension of the amygdala. And of course, you have fibers that, cortical fibers that are over all this here that don't belong to the temporal stem. So in order to do a temporal lobectomy, for example, if you want to do an anatomical temporal lobectomy, you have to reach the ventricle, okay, and then you have to open the choroidal fissure, and then this will be detached because this is a natural space. But you have to cut the temporal stem. You always have to cut. You see here the superior extension of the amygdala, okay? And inside what you have, anterior commissure here, and this dissection was done by Leonard Heimer. This is anterior commissure, this is uncinate fascicle, and this peduncle is what we refer as temporal stem. And this is how the tumors go to the septal region. Again, if a tumor goes posterior to the anterior commissure, it will go underneath the putamen. And if it goes anterior, it will go to this region in between the anterior commissure and the uncinate fascicle. This is all ventral striatum that we already talked about, which roof is the anterior limb of the capsule. And we're going towards the septal region. So this is temporal stem. So temporal stem is continuous with this ventral striatum, which will be continuous with the septal region. In the last lectures of everything tomorrow, I'm going to be showing like a surgical dissection on all of this, a pterional view of all this. So in order to do a temporal lobectomy again, an anatomical temporal lobectomy, you get inside the ventricle from where you want, from a sulcus, from a gyrus, or from the Sylvian fissure, and you reach the choroidal fissure, you open the choroidal fissure, you see here the hippocampus, and this is the fimbria, and you open above the fimbria, okay, and you detach. But then you have to cut the temporal stem, and then you cut here just anterior to the vein of Labbé, and you remove anatomically the temporal lobe. Again, to emphasize, remember that the amygdala is incorporated through the globus pallidus to the brain, and here the anterior part, just medial to the head of hippocampus, is also incorporated. That's why the choroidal fissure starts here, posterior to the head of hippocampus. This is choroidal fissure. And you see the thalamus, and the thalamus is the head of the brainstem, and the thalamus is sitting here over the subiculum. Subiculum is the bed of the hippocampus, but it's also the bed of the pulvinar. Look, that's how it is. So when you open the choroidal fissure, you detach all this. This is a natural space, and then you have to cut the temporal stem to do a temporal lobectomy. Of course, then you cut here. So the pulvinar is sitting over the subiculum. And this is the lateral aspect of the transverse fissure of the brain that I'll explain briefly to you. So this is very important to understand. The anatomy of the temporal lobe is very complex, three-dimensionally. And it's one of the anatomies that you're going to be dealing mostly throughout your life as a neurosurgeon. You have lots of tumors, you have lots of pathologies. You're going to be dealing with this every day. So you have to understand, and a key thing is to know that this part here is incorporated in the basal brain. And this knot, this is choroidal fissure and ambient cistern. We're going to be talking about this briefly. And this thing sitting like this. The pulvinar is sitting over the subiculum. Key feature to understand the temporal lobe anatomy. Seen from above and trying to put all together, you have here the central core. And this slide shows what I forgot to show in other slides. This is the thalamus. See the thalamus here. So the thalamus is related with the posterior half of the central core, of the insula. And the head of the caudate is big. The head of the caudate is a big structure related with the anterior half of the central core. In between you have the anterior limb, and here the posterior limb of the capsule. And in between you have the genu that is buried inside there, but it's just next to the foramen Monroe, pretty much in the middle of the insula. So when you look here, you have to figure all this underneath here. Okay, so if you go upper, body of the ventricle is related with the posterior part, just like third ventricle. Third ventricle, since third ventricle is related with the thalamus, thalamus is lateral wall of the third ventricle, is related only with the posterior half of the central core, posterior half of the insula. Anterior half of the insula, you don't have third ventricle anymore. You're anterior to the foramen Monroe. You would have just anterior horn. And the body of the ventricle is sitting over the third ventricle. It might be very simple, of course, but you have to have this in mind. The body of the ventricle, lateral ventricle, is sitting in the third ventricle. The anterior horn of the lateral ventricle is anterior to the third ventricle. And they are in different floors. The body of the ventricle is in level 2. The anterior horn is in level 1, just like the third ventricle. Third ventricle and anterior horn, same floor. Body of the ventricle, floor above. Atrium, same floor as third ventricle because it's posterior. This very simple thing you have to have in mind because when you're dealing with a tumor here, you have to know, and neuronavigation will not tell you. You're not using neuronavigation all the time. And thing, is bleeding, you're not going to know where you are. And when it's bleeding, then you have to know where you are. So this topographic view, X-ray view, you have to have. So choroidal fissure is just related with the posterior half of the central core. And remember that this is all head of the brainstem, particularly the thalamus, that it's straight continuous with the brainstem. Have to have this in mind. So if you come to choroidal fissure, natural space, everything is separated. But if you came anterior, it is incorporated. Inside, this is temporal stem. Inside here, you would have the uncinate, the IFOF, the anterior commissure, okay, and the superior extension of the amygdala. You have to cut this in order to do an anatomical temporal lobectomy. And you have to open the choroidal fissure. And you see that the choroidal fissure starts at the half of the insula. Here you have third ventricle. Here you have the body of the ventricle. Here you have the anterior horn. Posterior you have the atrium. The atrium is posterior because the atrium is posterior to the thalamus, so atrium is posterior. Atrium has nothing to do with the posterior limb of the capsule. Atrium has only to do, unfortunately, with optic radiation. You cannot go laterally into atrium without damaging optic radiation. But when you're dealing with tumors here, getting the ventricle, you said, oops, I got the capsule. You didn't get the capsule. Because if you're posterior to the central core, no more internal capsule. Only problem, functional problem, real functional problem, optic radiation. So, have to have that. Now, if you are underneath here, no problems. You just have temporal stem, which you can cut, and this structures that you can remove, as you do most of the time. So this is a final view of all these pictures. You see the central, the semicentral semiovale with the corona radiata, continues with the internal capsule, and the sagittal stratum, So fibers belong to different compartments. But different compartments doesn't have all the fibers, of course. So you have to have in mind these concepts. With the tapetum down here, and if you remove all this, you have all these tapetum fibers. This dissection was done by Eduardo, my son. If you lift here, you have all these temporal structures underneath. The medial temporal structures have nothing to do with central core, neither with sagittal stratum. They are different. Temporal medial region, very important for many reasons, but it's a different concept, a different region. So temporal medial region is a different region. What people call neocortical area of temporal lobe is different. It's all the temporal lobe that does not include the parahippocampal gyrus and the hippocampus. Sagittal stratum is another thing very important because it's lateral to all this. Temporal stem is the peduncle that it's continuous with the ventral striatum. That this is already ventral striatum. Here will be temporal stem, here the temporal ventral striatum, and we went at the septal region. And here you can open the choroidal fissure. Everything here has nothing to do with the central core. Central core is related here. Thalamus is here, head of the caudate is here. Okay, let's see everything again, but from a different point of view and put another structures in. If you see here, of course, you see the uncus, parahippocampal gyrus. What sulcus is this? What sulcus is this? Collateral. Okay? Fusiform gyrus is called fusiform gyrus because it looks like an arrow. So this is fusiform gyrus. This is sometimes it's not clear as this, but looks like. And the tip of fusiform gyrus is pretty much related with the brain stem. So if you see something here, it's not fusiform gyrus anymore. What's the name of the sulcus that separates the uncus from the rest of the temporal pole? Rhino. Very important because hippocampal sulcus separates archicortex from paleocortex. Uncus is paleocortex. The rhinal sulcus is the second phylogenetically because separates paleocortex from neocortex. This is all neocortex. This is paleocortex. So renal sulcus is important. Not in this case. Here you can say it is. It's common from the collateral sulcus to be continuous with the renal sulcus, with the rhinal sulcus. Here it's not continuous, but here it is. Very, very, very frequent. What is this here? Some people make a confusion with rhinal sulcus. What is this? Pardon? This is the tentorium. You know the tentorium was here. That's why you have this groove here. Okay? This is the apex of the uncus. So you're seeing that the amygdala is here, and the hippocampus is here, body of hippocampus, and then tail of hippocampus. Well, but this slide at this point is to show the anterior perforate substance. This is olfactory tract. This is lateral stria. This is medial stria. This is optic tract, interhemispheric fissure, and liming insula, which you cannot see. These are the limits of what is called anterior perforate substance. It's a wall. It's a wall where you have the perforators, the lenticular striate arteries. Everything that is posterior to the optic tract is posterior perforate substance. Posterior perforate substance. So anterior perforate substance, medial limit, interhemispheric fissure. Anterior limit, medial and lateral stria. Lateral limit, liming insula, I'm not seeing here. Posterior limit, optic tract. Posterior to the optic tract, towards inside the interpeduncular fossa, everything is posterior perforate substance. Here you're seeing the floor of the third ventricle, the hypothalamic part of the floor, okay? You see mammillary body and you see pituitary stalk. Tubercinarium is that prominence you can see a little bit posterior to the pituitary stalk, okay? So this is the wall that it's called anterior perforate substance. What do you see posterior going around there, posterior going through there is the anterior commissure. You see that there's a piece of brain here. Remember, I showed you that the anterior peripheral substance is the basal wall of the ventral striatum. So let's go through this nice slide. A lot of information here. Optic nerves. What is this here? Looks like in the anatomy textbooks is written like a bicycle, how you say, bicycle gear? Handlebar, yes. Handlebar. What is this? Anterior commissure. It's exactly like this. What do you have between the anterior commissure and the chiasm here? What is this? The anterior wall of the third ventricle. And just to advance here, we're going to be seeing here to make it easy in the afternoon. You see here the cingulate gyrus and cingulate gyrus, and then you have superior rostral sulcus and inferior rostral sulcus. Inferior rostral sulcus is inside the gyrus rectus. Superior rostral sulcus separates the cingulate from the gyrus rectus. And you always have this curve here, this connection, that Yasser Gil called the cingulate pole, that puts together the cingulate gyrus together with the rectus gyrus. And posterior to the cingulate pole, you have three small gyri. The most posterior one is the paraterminal gyrus. And then you have posterior olfactory and anterior olfactory. I'm sorry. The most anterior one is the paraterminal, then you have anterior or parolfactory and posterior parolfactory. The paraterminal gyrus is where the indusium griseum ends. And it's so tiny, but it's so important because it harbors the septal nuclei. The septal nuclei are inside the paraterminal gyrus. Why are the septal nuclei important? Because they are the gateway to the hypothalamus. Everything that comes from the cortex to get to the hypothalamus have to go through the septal nuclei. Real septum, also called, because septum pellucidum, this membrane, is the false septum, and septal nuclei are the real septum where you have neurons. I'm showing this and to mention that this is continuous with the ventral striatum. Let's come back here. What did I remove to have this dissection? I did remove the anterior perforate substance and all the tissue that is inside here. What do I have here? I have the big magnocellular nucleus of Meynert. I have the ventral extension, the ansa peduncularis, that is not shown here anymore. I have the accumbens that will be here. So this is the ventral striatum. So you see the anterior commissure is indeed the posterior wall of the so-called ventral striatum. Okay? Understand this. And then what structure is this here? You have to know. What is this? What is this structure posterior here? What is this thing here? Choroid plexus. If this is choroid plexus, what is this hole there? Foramen Monroe. What is the anterior wall of foramen Monroe? Fornix. So this is fornix. This is fornix. Post-commissural fornix, because the fornix has a little piece anterior to the anterior commissure that goes to septal nuclei. You're going to be seeing this shortly. But most of the fornix go posterior to the anterior commissure, that it's called post-commissural fornix. If this is foramen Monroe, my laser point is in what part of the ventricle? In the body, of course. I'm posterior, so I'm in the body. If this is the body of the ventricle, what structure is this? Lateral wall of body ventricle. What is it? What part of the caudate? The body of the caudate. What structure is this here? Putamen. What structure is this thing? No, the gray one, the brown one? Claustrum. Okay. What is this here? Internal capsule. What part of the capsule? Pardon? Yeah, you have to know what is the, first say what you thought. What part of the capsule is this? No, what is this here? So what part of capsule is this? The? The genial. You have to have this in mind all the time. Okay, genial is next to foramen Monroe. So if you're operating a subependymoma here, and you're next to foramen Monroe, you see how close you are to the genial? So your patient can have cortical nuclear fiber problems. Okay, even hemiparesis, because the posterior limb is just next posterior, and the anterior half of the posterior limb, motor fibers. Okay, always have this in mind. So if you understood this, I want you to tell me where is this MRI finding here. So let's think together. What is this here? Now let's start. What is this here? Thalamus. You see that the thalamus is the head of the brainstem? So this is thalamus. What is this? What goes around the thalamus? Big. Of course, this is the head of the caudate. So this small lesion here is just underneath, inferior to the head of the caudate. Do you know what is this? Pardon? Let's see next slide. What is this here? Anterior commissure. Here it's right here. So this lesion is anterior to the anterior commissure. This lesion is at the base of the head of the caudate. So it's anterior to the anterior commissure. Here's base just to show, what are these two things here? Of course, the fornix. A cut is going here. You see the anterior commissure, and you have two dots that are the fornix coming here. Post-commissural fornix in each side, right? Okay. What is this here? What is this here? What is this here? Yeah, don't be afraid. You have to believe in what you know, right? Professor Yassajil says, the more you know, the more you see. The more you see, the more you know. Okay? So what is this? What is this? What is this here? Accumbens, ventral striatum. So again, our lesion, as we know, is just inferior to the head of the caudate, underneath the accumbens. So anterior to the anterior commissure, underneath the accumbens. Okay? So our lesion is right here. Our lesion is right here. You agree? Anterior to the anterior commissure. Accumbens would be here, is inferior to the accumbens. Hence posterior to the anterior perforated substance, which is the anterior wall of everything. Our lesion is right here. So if you know these details, you know exact. Of course, you don't want to get there, right? Maybe with the laser, but this lesion was an incidental lesion. They seem to have different natural histories. Okay, very interesting slide this. What is this here? Yeah, it's inside here has the cortex, here without cortex. Okay, what is this structure? Pardon? Anterior commissure. The anterior commissure, its function not important anymore, but it's such an important landmark for us neurosurgeons and neuroradiologists and for anatomy. So you have to know everything about the anterior commissure. We're going to be showing something new about the anterior commissure. So this is anterior commissure going behind the accumbens. So, and this is amygdala. Optic nerve, optic tract. Okay? This is mammillary body. What is this here? Ansa peduncularis. The most posterior fibers will go to the hypothalamus and to the thalamus. The most anterior fibers will go to the septal region, that will be here. Up here, I'm sorry. Here you have the anterior perforate substance, not dissection at this side, right? So this is intact brain, anterior perforate substance. So what is this here? In the surface of anterior perforate substance. That is the most superficial part of the ansa. Are the fibers that are going to the septal region. What is it called in anatomy? Diagonal band of Broca. You see, it's hard to understand these things. I took years to understand these things. You know, I had to read in many different ways because anatomy textbooks are written to grad students and to anatomists. They are not to surgeons or to practical anatomists as we want to be. So this is the famous diagonal band of Broca, the most superficial part of ansa peduncularis. Okay, that fibers from the amygdala are going to the septal region. And the fornix is coming posterior, mostly posterior to the anterior commissure, coming here towards the mammillary body. What do I have covering anteriorly the accumbens? What is this coming from temporal medial to basal frontal? What bundle of fibers is this? Uncinate fascicle. You see, it opens like a fan, both sides. If I remove this, I see the accumbens. So the same thing we talked about seeing from anteriorly. This is a beautiful dissection. What is this? What is this thing here? Anterior commissure. What is this thing here? This part of the fornix post-commissural fibers will go towards the mammillary body. And what is this thing here? The pre-commissural part of the fornix that, of course, will be going to the septal region that was removed here, right? What is this? This is the? And what is this here? Olfactory tract, right? So this region is called olfactory trigon, right? What is, you see this thing coming here? Look how interesting. Theodor Meiner already described that was in the 19th century, that the anterior commissure had two parts, one hemispheric part and an olfactory part. This is the olfactory part of the anterior commissure, showing that this was the main commissure in reptiles that did put together both regions that used to be called the rhinencephalum. This is a term that is not used anymore. Of course, it did put together the amygdala, the very old temporal medial regions, and the olfactory system. Just as we said in the beginning of the lectures, these structures came together. So this was the main commissure in reptiles, and they are still there. Of course, we don't need this. We don't use this. Our olfaction is not this good, okay? But it's still there. It's a vestigial structure that is still there. We already went through the slide. This is seen from below. You see here the fornix coming to the mammillary body. You see here the anterior commissure, and you see how beautiful this branches of the anterior commissure going to the olfactory trigon, you know, showing that this was important at some point. This is hippocampus here. We're coming back to this. Again, amygdala, hippocampus, anterior perforate substance, the wall, anterior wall of the ventral striatum. Septal region will be inside there. Let's see the arteries. You have the bifurcation of the carotid. It's always, always underneath the anterior perforate substance. Always. Let me just come back here, something I didn't emphasize. Why did I put this slide here? What is this here? What is this flow void here? Carotid, M1 and A1, you agree? So this is the bifurcation. When you see the bifurcation, is because just next you have the anterior perforate substance. When you open the choroidal, when you open the Sylvian fissure, when you see the bifurcation, you're not seeing, but just posteriorly, you have the anterior perforate substance where the penetrating the vessels are going to, the lenticular arteries, okay? So when you see this, is because you are seeing the anterior perforate substance. So I wanted to say that this lesion was behind the anterior perforate substance. Behind. So it was inside this piece of brain, wasn't right in here, as you already concluded. So if we come here, if we see the bifurcation, all these arteries are going to this is the anterior perforate substance. You cannot see this surgically in the pteronal view, okay? Where are these arteries going to? Look how interesting. They are going through the anterior perforate substance, okay, of course underneath the uncinate and the hypoph and the so-called temporal stem. Here's the uncinate. There's the anterior commissure. You see the anterior commissure, and it's interesting because mostly of them are going to through the ventral striatum and anterior to the anterior commissure, and not posterior. This is very important because if you have a lesion here, it's not this dangerous as having a lesion here. If you have a cavernoma here, as we already had, you can go pretty safely. You're going to expose the inferior limiting sulcus of the insula, and if you open it posteriorly, you're pretty much avoiding big lenticular striate arteries. I think this is the future of microneurosurgery, and to know the details of these vessels. And maybe going there, I don't know, maybe in the future robotically or whatever, you know, and really know exactly where we are with intra-op technology, seeing vessels and so forth. You see how interesting? Most of the vessels goes anterior to the anterior commissure. Okay, now let's do a dissection from below. Okay, you see how beautiful the fusiform gyrus. And let me advance and tell you that the fusiform gyrus is the real floor of the ventricular cavity. We're going to come back to this many times. And the anterior half is related with the inferior horn. Posterior half is related with atrium. The atrium is here. Inferior horn is here. Anteriorly, you don't have ventricle, as you know. So let's dissect this. If we start dissecting, you see a bundle, pretty much well-defined bundle, inside the fusiform gyrus. Does anybody know what bundle is this? Inferior longitudinal fascicle. Don't you have the superior longitudinal fascicle I showed you? Has 3 parts. This is the inferior longitudinal fascicle. What is functionally related with? Does anybody remember? Neurologists say that it's related with facial recognition, okay, mainly, and with other functions as well, secondary functions. For us, what is important is that the inferior longitudinal bundle fascicle is inside the fusiform gyrus. You see, it ends here. It ends here. The arrow ends at the level of the brainstem. If you continue, you expose the ventricular cavity, of course, because the fusiform gyrus is the real floor of ventricular cavity. So you're exposing the hippocampus. And what is this anterior to the hippocampus? And of course, the amygdala. And you have the roof of the ventricular cavity. Let's remove the hippocampus. You're seeing the roof of the inferior horn. If you see gray matter in the roof, what gray matter is that? We already talked about this. Cannot be any other thing. You're seeing gray matter in the roof of the inferior horn, the tail of the caudate. Cannot be anything else. Okay? And the tail of caudate, let's see next slide. Look how beautiful. Tail of the caudate. It will end at the amygdala. This is the amygdala. Remember? Hippocampus and amygdala. If I remove hippocampus, I see better the amygdala. The tail of the caudate, olfactory tract. What is this? What is this? Pardon? Lateral geniculate body. Lateral geniculate body. And what is this here? Where is it coming from? Stria terminalis. It's the dorsal, just like you have the ansa peduncularis anterior, you have the stria terminalis posterior, the dorsal extension, always medial to the caudate. And when it gets to the lateral ventricle, it's medial to the caudate, next to the thalamus, right? Underneath what? What runs in between the caudate and the thalamus, the body of the caudate and the thalamus? Pardon? Yeah, the talostriate vein. Remember that when you go to the lateral ventricle, the stria terminalis will be underneath, running underneath the thalamus-striate veins, and will end at the bed nucleus of stria terminalis at the base of the head of the caudate. Okay? Stria terminalis. Lateral geniculate body. Once I had a GBM starting here, and of course you have to go to the ventricle. This is very high. It's very difficult to reach. Everything that is the upper part of, what is this? What is this gray matter here? What is this? This is very important for epilepsy surgeons here. What is this gray matter here? Is this? What is this? Remember that the amygdala is anterior to the head of the hippocampus and covers the head of hippocampus. So it's in the roof, anterior part of the roof of the inferior horn. That's why when you remove the amygdala, you cannot remove the most superior part of the amygdala, right? Because you don't see it. You don't see it, you know. When I'm operating these region tumors, I don't do epilepsy surgery. I did a little bit, but enough to learn this region. I think this is one of the main schools to learn this anatomy, is to stay a little bit with epilepsy surgeons. Everything that is superior to the M1 is hard to go, you know, because you cannot see. You cannot see. You don't have a view to see. So this part of the amygdala is going superior, and it's going to merge with what? With the globus pallidus. Remember that the amygdala merges superior with the globus pallidus? We want to introduce this, optic radiation, anterior commissure. Now let's remove the fusiform gyrus. If we remove the fusiform gyrus anatomically, you see that I expose the ventricle. So the fusiform gyrus is the real floor of the ventricle. You see that its anterior half is related with the inferior horn. Its posterior half is related with the atrium. Okay? We're going to be seeing tomorrow that this is already sitting in the tentorium. This is over the petrous bone and a little bit over the middle fossa. You have to know where these things are, you know. You have to know. We'll see. We'll show it tomorrow in tumor surgery. So this is the fusiform gyrus removed. And now what I'm going to remove this gyrus. What is this? What gyrus is this here? What sulcus is this? Calcarine. If this is calcarine, what gyrus is this? The lingual. The lingual. So if I remove the lingual, what gyrus is left here? The cuneus. Okay? And this is the depth of what? The calcarine fissure, right? This is the calcarine fissure. And you see that almost reaches the ventricle. This is the bulb of callosum. The calcareous would be posterior here, was to remove together with the lingual gyrus. And what gyrus is this? What sulcus is this? Where is this dissector, the pain field? What sulcus is this? Parieto occipital, exactly. Parieto occipital, this is the cuneus. This is the inside the calcarine fissure. This is the callosal bulb. This is the parahippocampal gyrus. This is hippocampus, inside the ventricle. Parahippocampal gyrus, seen from below. If I remove, I can see the fimbria here, going around the thalamus. If I cut the fimbria and remove choroid plexus, I can see again the roof of the inferior horn. And this is to emphasize that there's no separation, no fissure between the roof of the temporal horn and the thalamus. This is thalamus. That's why to do temporal lobe surgery, you have always to know where the ventricle is. If you go superior to the ventricle, if you're operating a neocortical GBM there, and you go superior to the ventricle, you're going to get inside the thalamus. You know, so you don't want to do this, of course. So when you're doing temporal lobe surgery, you can, if possible, expose the ventricle. If you don't expose or you don't need to expose, know where the ventricle is, you know, in order not to go superior to it and get into the thalamus. No separation here. So you see, there's no separation from the temporal lobe here to the thalamus, and neither from the thalamus from the brainstem. It's a continuum. Let's see again everything now from anteriorly. If we go at the level anterior limiting sulcus of the insula, you see the anterior surface of the insula. This is anterior limb of the capsule. This is the head of the caudate, of course, because we are in the anterior horn. If we remove more, this is the rostrum, trunk of callosum. What is this? Of course, lateral wall of the anterior horn. I didn't get to the foramen Monro yet. So this is the putamen, this is the claustrum. Where is the anterior limb? It was not well developed. As I said, this specimen has a real striatum, corpus striatum. You don't have a very well developed anterior limb. You're never going to see this in the posterior limb, but in the anterior limb sometimes you see a not very well developed anterior limb. If I go more posterior, I start to see the anterior commissure. I'm still seeing rostrum here. If I go more posterior, I already talked about this slide. I see already foramen Monro, so this is the genu, okay? If I go more posteriorly, I cut the anterior commissure. I see the post-commissural part of the fornix going towards the mammillary body. If I come back here, of course, this is the anterior wall of the third ventricle, lamina terminalis, and this is the floor of the third ventricle. And you see that the mammillary body divides the floor of the third ventricle anteriorly in the hypothalamic part and posteriorly in the midbrain. And what part of the midbrain? The roof of the interpeduncular fossa. So the roof of the interpeduncular fossa is still floor of the third ventricle, right? Anterior to the mammillary body, you have the tuber cinereum, and then you would have the pituitary stalk. Continue removing. I have here the posterior limb of the capsule. Here would be the foramen Monro, so this will be the genu. And you're seeing that we're dealing with the posterior part of the central core. Posterior half of the central core. If we remove the posterior half of the central core, we expose the third ventricle. So the third ventricle is related only with the thalamus, hence with the posterior half of the central core. Anterior commissure. Postcommissural fornix, anterior commissural fornix, going to the septal region that will be here. Chiasm, lamina terminalis would be here, okay? This is the floor, mammillary body. Tuber cinereum will be here. This is the infundibular going towards the pituitary stalk. The small hole here is the infundibular recess. The hole in here would be the optic recess, right? Third ventricle has 4 recesses. Optic recess, infundibular recess, pineal recess, and suprapineal recess we're going to see later. This is floor. Aqueduct will be here. Look at beautiful hypothalamic sulcus. From here, superior, this is thalamus, massa intermedia. This is hypothalamus. Okay? You see how high foramen Monro is? In the past, they used to cut the colon of the fornix to operate in the third ventricle. You see you don't gain anything. You have to open the choroidal fissure or go interfornicial to expose the whole cavity. We'll get into that. And this is the stria medullare of thalami. The stria medullare of thalami comes from the foramen Monro until the abenula. And it harbors fibers that come from the fornix, fibers of the so-called medial bundle, medial frontal forebrain bundle, medial forebrain bundle, okay? And other fibers from the hypothalamus, I don't remember exactly. But mainly from the fornix and medial forebrain bundle. And they come from this region to the abenula. Later on, we're going to be talking about this velum interpositum region that is very important to understand as well. We'll come back to this. Choroidal fissure. What is important about choroidal fissure for us? This thing. If you open choroidal fissure just posterior to the foramen Monro, you're getting into the ventricle. Now, if you open choroidal fissure in the pulvinar, where do you go to? You go to the pineal region. Tomorrow, if we have time, you're going to see a meningioma, this region, that goes to the pineal region because the meningioma went through the posterior part of the choroidal fissure. So, very important for you neurosurgeons. If you come back here, if you open the choroidal fissure anteriorly, you're reaching the third ventricle. If you open the choroidal fissure posteriorly, you're going to the pineal region, that it's underneath the splenium. Okay? If you open here, you're getting in here. Have to have this relationship in mind. Now let's come back here. Let me see okay. Let's come back to this floor. You see the tuber cinereum would be here and infundibular recess here. Tuber cinereum is pretty much reddish. If you go with the endoscope, this is lateral ventricle. If you see choroid plexus, foramen Monro, septum, okay, everything that is medial is fornix. So this anterior wall would be the fornix, continues with the rostrum of callosum. If you get into the third ventricle, you see the mammillary body, and you see this reddish area, which is the tuber cinereum. You want to do your third ventriculostomy here, not only because this is thinner, because here don't have axons. From here, you see the infundibular recess here. From here, going here, you have axons that come from the tuber cinereum that are going to the pituitary stalk. So that's where you want to open. And if you open, of course, you get into the cistern where you see the basilar artery. You see, again, very thin here, usually just anterior to the mammillary body and the tuber cinereum, and the infundibular area is anterior to this. If you see posteriorly, what hole is this? The aqueduct. What is the superior limit of the aqueduct? Posterior commissure. And what is this thing here? Abenular commissure. So you have one abenula here and another abenula here. Okay? So what's the name of this space here? This is the pineal recess. And this is the suprapineal recess. So let me come back here. No, this slide doesn't show very well. Well, here. You have the stria medullaris that go into the abenula here. From this abenula to the abenula our side, we will have the commissure of the abenula. And here you have the aqueduct. This is the posterior commissure. The pineal gland is attached to the brain with two arms. The inferior arm is holding the posterior commissure, and the superior arm is holding the commissure of the abenula. In between them, you have the pineal recess. Okay, don't forget, pineal gland holding, it's attached holding with the inferior arm the posterior commissure, and the superior arm the commissure of the abenula. And in between these two, you have the pineal recess. And superior to the abenula, to the commissure abenula, you have the suprapineal recess. So if you come here, you have the aqueduct, pineal recess, and suprapineal recess. This is the commissure of abenula, this is the posterior commissure. And here you have the stria medullari of thalami, talked about. This is the fornix. We're going to end talking about this space here with the cisterna velum interpositum. Here you're seeing the fornix, mammillary body, mammillothalamic tract, that part of the Papez circuit. This is third nerve, midbrain. This is the red nucleus. What nucleus is this here? Under the thalamus. The subthalamic nucleus. Never saw it dissected as Richard did. Subthalamic nucleus. And this is a tract that comes from the abenula to the interpeduncular. Abenula interpeduncular tract that has a classical name of fasciculus retroflexus of minor retroflexus fasciculus, okay? Is this thing here. And this is third nerve. Retroflexus fascicle of minor, subthalamic nucleus, red nucleus. This thing goes in between the red nucleus, as you can see here. Now, let's end talking about this. This is a space inside the roof. We didn't talk very much about the roof of the third ventricle, okay? The roof of the third ventricle has a superior thalacoroidea and inferior thalacoroidea. Superior thalacoroidea is attached to the fornix. Inferior thalacoroidea is attached to the stria medullari of thalami. Is in this space here. The choroid plexus is coming through the choroid fissure. So it's in the floor of the lateral ventricle, is in the roof of the third ventricle. Okay? Now, in between the two thalacoroidea, superior and inferior, you have this space here. This space is a cistern. It's within, inside the roof of the third ventricle. This cistern is called velum interpositum. Can anybody tell me what do we have running in here, inside here? Exactly, posterior medial choroidal arteries and the internal cerebral veins you have here. Now, this is the pineal, right? Gland. So what's the name of this space here? Subsplenial, okay, but if you talk about cisterns, what is this? The pineal cistern or quadrigeminal cistern. So the velum interpositum cistern is the anterior extension of the pineal cistern, okay, as you can see here. Now, this is the last slide, but I don't want you to look at the slide. I want you to finalize showing something that it's very important to end this part of the architecture of the inner brain. Maybe we can have the lights here, please. Can we turn on the light and then? We have two main fissures in the brain. Two main fissures. One is very easy to understand, is the interhemispheric fissure. Interhemispheric fissure. Then we have another fissure that was described by someone called Bichat in France 200 years ago. is the transverse fissure of the brain. What is the transverse fissure of the brain? First, let's understand something. When we say sulci fissures, we're talking about a space in between gyri, a space within the brain. When we talk about cisterns, we're talking about a subarachnoid space. For example, the Sylvan fissure is inside, the Sylvan cistern is inside the Sylvan fissure. Two different concepts, okay? What is the transverse fissure of the brain? The transverse fissure of the brain takes the Sylvan fissure, where you have the Sylvan cistern, takes where is the crural cistern, which is the most inner and upper aspect of the Sylvan fissures, then go to the ambient cistern area. What is the ambient cistern area? The ambient cistern area is that area in between the pulvinar and the subiculum that I showed you. That's where is the ambient cistern. That's why people say the wing of the ambient cistern, because it opens laterally towards the dentine nuclei. Remember the dentine nuclei, the femorodentate space? This is the most lateral part of the ambient cistern, called the wing of the ambient cistern, and most lateral part of the transverse fissure. The ambient cistern is inside the transverse fissure, just like the Sylvan cisterns are inside the transverse fissure. The pineal cistern is inside the transverse fissure. And then the transverse fissure gets inside the velum interpositum. So this is a continuum of a natural space that it's transverse to the brain, just perpendicular. Interhemispheric fissure, very easy. And then if you take this, where are the Sylvan cisterns, the ambient cistern, the crural cistern, ambient cistern, pineal cistern, and cistern of velum interpositum, this is all transverse fissure. This is what Yasagil tried to show in this drawing here. This concept, it's not practical. We don't use it. But if we understand the architecture of these spaces, you see. And tomorrow, if we have time and show some ventricular surgery, we're going to understand why tumors, benign tumors particularly, why they go through natural spaces also. Okay? Okay, I think that's what I wanted to show this morning. And if you have questions, and sorry if I spent too much time here.
So, yeah, why don't we open it up? Any questions about the anatomy portion? We have time for lab or
Maybe sure. Yeah. No membrane. It's continuous. You have CSF, the CSF goes through all the spaces. You know, it's continuous. It's continuous. All the cisterns are continuous. So velum interpositum cistern is not a closed space. It's a space that goes from the foramen Monroe anteriorly. It's closed there in the foramen Monroe. It's just like a finger that went there. But posterior, the finger opens in the pineal cistern, just like the pineal cistern is continuous with the ambient cistern, which is continuous with the Sylvan cistern. Right? This is a continuous. This is the transverse fissure of the brain.
If you think about it, the internal cerebral veins have to drain out of there into the vein of Galen, along with the basal vein of Rosenthal. They have to both travel through this space continuously to get to the
right
science. So that has to be the space.
Now, I always thought and discussed this with many other surgeons. The pineal tumors, how do they get into the third ventricle? The big pineal tumors, they get into the third ventricle through the suprapineal recess. That's what I understand and what most of people understand. They don't get inside the velum interpositum. Okay? They can even block the velum interpositum because they press in the velum interpositum from inferior to superior. But they go through the space superior to the suprapineal, the suprapineal recess that I showed. That's how they get there. That's why if you have a pineal tumor And if your splenium is very low, it's hard to get into the third ventricle. If the splenium is it's put superior, it's going to be easy. If the splenium is down, it's going to be difficult, you know. There are details anatomical. Tomorrow maybe I can show you those better.
All right.
Okay.
Thank you very much.